All right, so let's get started. We're going to start with benign neoplasms. Okay, so seborrheic keratosis is a stuck-on lesion. So remember, it's stuck on where seborrheic dermatitis is cradle cap, is how you can remember that. It's hyperkeratosis lesions of the epidermis. It's got that well-circumscribed border and is usually rough feeling. If you see a bunch of SK show up all at once, that's called a lesser Trachelo sign. So multiple appearing could mean a GI malignancy. So you need to like be on the lookout for that. Acanthosis nigrans is associated with endocrine disorders like diabetes or insulin resistance. And it also could be, again, like a visceral malignancy like GI or obesity or Cushing's disease. So on histology, you're going to see an orthokeratotic, hyperkeratotic papillomatosis of the striatum spinosum, as we can see right here. So as we can see here, we can see skin tags. So acrochorion or fibroepithelial. They're cutaneous papillomas. They've got a fibrovascular core. There's no adnexa. It's covered by squamous epithelium. They're these like soft palpomatosis growths that are flesh-like colored to dark. A lot of it is due to friction, and you'll find them in areas that rub together, like neck folds or groin. Okay, epidermal cysts are going to be cysts lined by squamous epithelium with a granular layer and keratin debris. So it's got this like creamy cottage cheese-like texture. With Gardner syndrome, there's FAP osteomas, epidermal cyst, and pileomatricotoma, which we'll learn about in a little bit, and we'll talk more about Gardner syndrome as well. Okay, so now we are at the top of the head, so pilar cyst. It's most common on the scalp. They're cysts lined by squamous epithelium, and they don't have a granular layer. So we can see that right here. Adnexal tumors differentiate along an adnexal line, like hair follicles, sebaceous glands, apocrine glands, or eccrine glands. So the first type we're going to talk about is the Equine Poroma. It's common on the palms and soles. They have these cords and nest-like structures of small keratinocytes that are delineated. So we see right here this like purple cord-like nest structure. So you'll see this like sessile pedunculated nodule, and it may be erythematous as well. And we can see that right here. And it looks like it's on like maybe like the pad of a finger or a toe. Okay, here's another one that is on the scalp. Cylindroma. Easy mutation to remember. It's CYLND or CYLD, sorry. Just like cylindroma. There's two different forms, the Turbine Tumor form or the Brooks-Spindler syndrome. It has these complex nests, as we can see, like the last one that had nest. These nests are cords in nest. These are also in nest, and they have basaloid cells that kind of fit together like a jigsaw puzzle. So if you see this dark purple jigsaw puzzle nest, know that that's a cylindroma, and they have these little spherical pink droplets inside. They, looking at it, grossly, they are pink, red dome-shaped nodules with a smooth surface. Okay, so now we're looking more at the eye. We have syringiomas, which are most common in the lower eyelids, derived from the sweat gland ridges. They have these like small duct sclerotic stroma with these double layer cells. So you can see right here, we have like here's a single layer, and then we have some that are double layers. There's multiple yellow papules under the eyelid. And right here is like our sweat duct ridge. Sebaceous adenomas, the mutation is MSH2. It's associated with Mutour syndrome, which we'll talk about. They have this nodular or lobulated growth with generative cells and sebaceous cells. So the dark color is our growth generative cells, and this light color is our sebaceous cells with that cytoplasmic lipid vacuoles, as we can see here. And the papal nodules are on the face and scalp. So back to Mutour. Mutour syndrome is a neoplasm of the skin with a visceral malignancy. The subtype of this is like HNPCC syndrome or Lynch syndrome. It's associated with an internal malignancy. Know that it's associated with MSH2 and 1, which are the mismatched repair genes. So we can see these sebaceous tumors and papules, and remember that it is associated with Lynch syndrome. Pileometricoma or calcified epithelioma of Malherbe is going to be a CTNNB or B beta-catenin mutation of BLC2 overexpression. So this is like catenin beta is how you remember it. And so just know that pileomectrocoma is associated with this. It has these solid nests, again, nest-like structures with eruptive keratization, and then these ghost cells. So we have these solid nests, and then we have these like little cells that look like ghosts with calcifications or ossifications as well. Trichoepithelioma are going to be a CYLD association. They have these basaloid cells forming primitive hair follicle germ structures that are peripheral cell palisading. So we can see in the histology slide that we have these palisading structures, cells located here, and know that it's where a hair follicle would be. They're slow growing papule nodules located many times on the face. Trachelo Moma, which we had just sort of mentioned, they are derived from the outer root sheath hair follicles. It is associated with Jacinto neoplasm and Cowden syndrome, which are, it would be important to know Cowden syndrome. It has multiple trichomas, hemoromas, and malignancy associated with it. On histology, you see these pale pink glassy cells that are palisading. We can see that it's these pale cells palisading here, and it's palisading right here at the periphery. So we can see that. And you get these like warty papules located on the face. So no Cowden syndrome, multiple trichomas, hemoromas, and malignancy. Dermatofibromas are associated with acanthakin 1 and FGFR2. On histology, we can see this Grins zone. That zone is super important to remember. And so what happens here is that there's going to be collagen trapping by dermal fibrohistocytic infiltrates. They're going to be non-encapsulated story-form growths of fibroblast. So no, this Green's zone and with dermafibromas. Associated with dermofibroma are dermofibrosarcoma protuberans. So it's a COLA 1A1 PDGFB mutation. I would make sure that I knew that mutation for this disease. It has a tight storiform pattern, so we can see how tight it's located right here compared to some of our histology slides. They have these cells that are radiate in spokes. So we can see like right here, it's like, it sort of reminds me of like Starry Night pattern. Like if you look at that painting, it kind of looks that way. So we have like all of these like going in different directions around like a central point. So like see how it's all going to one point. So this central point contains a vessel and it's going to entrap fat. So if we take a really close look, we can see these adipose cells. The plaque is irregular red violaceous and indurated papule that has firm irregular nodules. So if you see these firm irregular nodules, know that that's a dermofibrosarcoma protuberans, and it's associated with COLA 1A, 1 PDGFB. Okay. Neurofibroma. So we've got neurofibroma in NF1 and NF2. It is a spindle cell tumor with nerve sheath differentiation. It's flesh colored and it may be plexiform. It has a NF1 association if it's plexiform. And then we'll talk about NF2. It's S100 positive and CD3-4 and FX3A positive as well. So NF1 or von Reichenhaus disease is a mutated neurofibrin on chromosome 7. It's important to remember this for boards as well as your exam. So multiple neurofibromas plus greater than 6 cafe au lait spots, which we had talked about cafe au lait spots before. They're either these light spots or dark spots on light skin or light spots on dark skin that are macules. And then there's leash nodules, which are in the iris associated, which are pigmented hamartomas, and then malignant peripheral nerve sheath tumors and optic gliomas are associated with this. So that is an NF1. So make sure you remember this. NF2 is associated, I think, more of like schwannomas and acoustic neuromas. Remember, acoustic neuromas, they're going to go in the IAC, so they are wrapped around usually cranial nerve 8. So that affects hearing as well as vestibular function, like it could affect balance. Since also facial nerve travels in the IAC, it can also affect the facial muscles and cause drooping of the face. These patients have also multiple meningiomas and then spinal cord ependiomas and schwannosis. They also have cafe au lait spots, but it's important to note that they don't have leash nodules. That's only an NF1. So doing a bunch of neurosurgery rotations this semester, or not this semester, this year, I have been able to see a lot of NF1 and NF2 and a ton of like schwannomas. So it's a really interesting surgery to see. I would obviously recommend seeing at least one, but I will tell you it's sometimes can be like a 8 to 10-hour surgery. But it is really interesting to see how these schwannomas encapsulate and really wrap around a nerve. And it's really important to preserve that nerve because you don't want to lose function in a patient's face. So they try to remove as much as they can, but can't always get it. And then schwannomas come back, especially if they have NF2. So right now I'm at the NIH doing my last rotation, and I've seen this a bunch here. I mean, I've seen it at every rotation, but Um, it's kind of cool, and they're doing research on this as well. Okay, so here's another brain picture. So here's the schwannomas. So they're biphasic, ordered cellular components that palisade. There's also Verricae bodies. So we have Antony A and Antony B. So Antony A are going to have that, are the components that palisade, as we can see here. And then Antony B has that myxoid component. Um, so All right, so we're going to stop there, and then we'll start back up again with melanoma.